everyone. Just a moment. Can you all hear me?
Yes, ma'am.
Yes. Good evening, everyone. So I would like to introduce the faculties for today, Ms. Shalini as well as Mr. Syed Askari. Ms. Shalini is the national lead of facilitation team at Pallium India. She is an ex-corporate management professional with 18 years of experience in MNCs like Genpact. In the corporate world, she delivered through leadership roles in operations, project management, business development, client relations, advocacy, and training development. Inspired and influenced by Dr. Rajagopal's work in palliative care, she made a move to the development sector to work for palliative care with Pallium India since 2016. The next faculty is Mr. Syed Askari, who is a regional facilitator of Pallium India. He is an MBA graduate and has worked on projects related to disabilities, the environment, and livelihood. For the past 8 months, he has been working with Pallium India as a regional facilitator, handling Northern India region based in Delhi. Thank you, and over to you both for today's session.
Thank you for the nice introductions, and good evening, everyone. I don't know, some of you might know we have met. I can see some familiar names here. It is a great opportunity to be talking to you about how palliative care services can be developed in your setup. So I would just be taking a back seat here. Syed would be the one who will be leading the presentation. And anywhere you have any questions, please feel free to ask any of us. Thank you. Over to you, Syed.
Yeah, good evening. Thank you so much for this opportunity, and thank you for all those who have joined this workshop. So, can I share from my side?
Yes, Syed, you can.
Okay, just I'm sure. So I'm audible now?
Yes.
Yeah, so hi every participant. Now just we have a topic regarding organizing the palliative care. It's a very different things because as Shapia said that it is connected to admin and like a management thing. You people are working with the patients, and we are people who are connecting those patients with person with who working in a health sector. So our work to just create an environment so you can work easily in palliative care. So you are seeing this is our directory of palliative care in our website in Pallium. So the data shows that Kerala has 60% of all palliative care centers in India. So you can say 549 out of 962. And now we have covered 28 states and 6 union territories. So some union territories and state have remained. So just 3 union territories have remained in DNH and DND and A and Iceland. So we have to work on it. And definitely we are working. So if you wanted to find any palliative care center near you, you can go through our website on our directory platform. You can find the state-wise, city-wise over there. So it's a very good platform to finding a palliative care center near you. So now we are working in a WHO palliative care advocacy triangle. So how we are working? We are working through education, drug availability, and with policy. So the Indian context, we can say delivery broadly classified into 3 major categories. First is standalone. It may be a hospice or a palliative care center. Second is a department unit within a hospital. It may be a department in government hospital, charitable hospital, sustainable organization, or for profit. And third is our work is to community-based home care services. So these are 3 major categories where we are working. So it's just like example, our regional facilitator connected with these hospice. So standalone hospice, we can took a name of Institute of Palliative Medicines, Calicut, and Karuna Shrai Bangalore Hospice Trust. So these two are the example of hospice.
Syed, if you'll just go back, I would just want to share a couple of things about the hospices.
Right,
Yeah,
right.
thank you, thank you. So, because all of you are from different locations in India, we also wanted to give you an update that the hospices in India is a very, very new concept. So we are still struggling with palliative care services itself, but still there are groups of people who have created hospices where the patients can come for end of life care or for a long-term stay. So the first picture is about Pune, Cipla Pain and Palliative Care Center. The second picture where the group is saying, you can read the name Ruma Abedna Hospice, that is in Kolkata, West Bengal. The third one is the Chandigarh Hospice, where you see one of our regional facilitator from North, Rajendra, standing. The Chandigarh Hospice is in Chandigarh, again taking care of the palliative care and cancer patient there. And the other one is Shri Guru Ramdas Hospice in Amritsar. So these are coming up in their solo efforts in different sections, but they are just doing it as from their own side. They are not so well equipped with all kind of facilities, but in their own own efforts, they are coming up. So our endeavor is to support them in whichever way they want. Any questions from anyone in regards to what is a hospice? Or anybody can explain what is a hospice? The question to the audience. Anyone bold enough to answer what is a hospice? What is the difference between a hospice and a palliative care center?
Hospice, good evening, ma'am.
Yeah, hi.
Hi.
Dr. Sheila Rathore, right?
Yeah.
Please go ahead.
So hospice is actually, it is a facility which provides palliative care and emotional support to the terminally. It's most like a home. It's like an home, I mean, to provide palliative care and emotional support to the terminally ill patient.
That's correct.
It's like more of like a home-like setting, I mean.
Yeah, and
the family members, everyone can be equally involved in the care, including the family members and the community.
Okay, and what is a palliative care center or a hospital?
So in a hospital, it's mostly it's not going to be active participant from the family or from the community or something. It's just going to be like a proper hospital setting. I mean, like some other hospitals.
Okay.
And palliative care is for hospice is for the end of life usually, where end of life care is given more, and palliative care may be more in the early stages as well. Set up, it may be from diagnosis, symptom control throughout the trajectory, and hospice is usually towards the end of life.
Thank you, Dr. Sheila and Dr. Divya, for your inputs. The primary difference between hospice and palliative care centers are the duration of the stay of the patient. Now, hospices, generally people go during the end of life care. However, there are places where people still go for short stays and then they go back home if the home care services are being delivered by that hospice also. So it need not be always end of life care, and it need not be always with patient's caregiver also, because even in a palliative care center, one of the basic aspect of palliative care is that we want to involve the family. So like in center in Kerala, where we are, Trivandrum, our center, we are a small hospital. We are not a hospice, but we still keep a caregiver with the patient always. There is always a caregiver or a family member supporting the care of the patient. So the primary difference is the stay, the duration of the stay. Hospice more of is a concept in Europe and US, where we have those old age homes, retirement living, and people are generally moved to hospice because they are end of life. However, hospice can also be utilized for intermittent stay for increase of quality of life. But thank you for participation. I just wanted to touch upon this aspect on this slide. Syed, please go ahead. Sorry to interrupt you. I'll try to stay quiet now. Syed, we can't hear you.
Yeah. Thank you, Shalini, for adding the some very important topics on it, and I hope the participants have clarity regarding hospice and palliative care center. So this is our community model. You can say the Kerala palliative care model, how they are working. They are working in a macro level, meso level, and micro level. So our focus of palliative care is quality of life. That means the meaning of life. Pallium India DF model. DF means that we are working in a facilitation, education, and demonstration model. So what we are doing in facilitation, we are working in advocacy and promotion of palliative care, awareness regarding palliative care. We are working on government programs, catalyzing palliative care centers, working for the opioids accessibility, working with state policy and with community engagement. And in education, we can say we are providing online and on-site training courses, on-site foundation training courses. As a demonstration, I'm just giving the some small thing over here, and the demonstration will be explained by Shalini. So these demonstration we are working with visits to tips like Trivandrum Institute of Palliative Sciences. We are working through implementation team, hands-on training and career. So these are our demonstration model. Shalini, can you please add some points on
Sure. So Pallium India, as the topic says, we are doing an organizing palliative care. We are going to support you if you want to open up a palliative care center, or if you're already working in a palliative care center, we want to enhance that center by working with you. For demonstration model, we always invite everyone to come to our site in Trivandrum, visit us here and see how we are delivering in inpatient, outpatient, or home care. We have community participation very strong in Trivandrum. So we have link centers where our home care vehicles go and then reach out to different patients in their houses. So once you make a visit to our center, you can see with your an experience with your own self. And I think most of the global fellowship participants will be coming here for some period. So any of you who are interested to see our model, which is more of community-based model, are most welcome to come to TIPS, which is our Trivandrum Institute of Palliative Science. It's a WHO collaborating center for training and policy for access to pain relief. Thank you, Syed.
Thank you, Shalini. So we are going to. So, and along with these palliative care centers across India, we have also providing the national helpline, Tele helpline. That's based on 4 languages: Malayalam, English, Hindi. So, whoever a person who wanted to search the palliative care center but not able to find in their state or city, they can call on this number. It will be very easy for them to connect with the palliative care unit, right? This is the catalyzing and enhancing how we are. It is our methodology, how the facilitation team working for the palliative care center, how we are catalyzing the palliative care center. Just wanted to give some points on it. So first of all, we are just planning whenever we are going to catalyzing any palliative care center. So if you go through the first point, that planning, recruitment, and budgets. So we see that the organization or the hospital are what is their budget, how they wanted to start their palliative care center. So we are helping them in recruiting, in planning, and budgeting, and documentation. And second is education and skill building. So if we just see that the doctors and the nurses and the healthcare provider, they require a training. So we are also providing the training offline and online training as well. We are also supporting in opioid access. We are also working through implementation, quality care, monitoring impact. We have some some quality care monitoring. I will show some pages on in the next slide. We are also providing community engagement, and our goal is to reaching 10 million by 2030. So these are some methodology. I just wanted to call Shalini if you wanted to add some point on it, please.
Thanks, Syed. I would just want to share that we have around 6 regional facilitator based out of India, based out of different cities in India. So as you see, Syed is based out of Delhi. He's the primary contact for all our partners in North. Some of the states that he's handling, particularly J&K, Delhi, Ladakh, MP, Chhattisgarh, Gujarat, Daman. Similarly, there's another person who's working out of Dehradun, who's trying to support all of you who are trying to come up with a center in UP, Uttarakhand, Bihar, and Jharkhand. We have another person working out of Chandigarh who would be supporting Himachal, Haryana, Chandigarh, and Punjab. Then, of course, one person is in Guwahati, one person is in Pune, and one is in Chennai. This team, the primary objective of this team is after all of you get trained here, you want to go back and you want to start a palliative care center or your existing institute want to enhance it. What all struggles or barriers that you come across, you just have to share with us and we'll try to create solutions for you. These are the regional facilitators who work with their local partners to create solutions. Like if you see, as Syed mentioned, planning how exactly to go about. Suppose you do not have anything in your hand, you're just an individual who has just taken a training. Now, how to plan further? Should you start with an OPD or should we start with an IPD? Or do you think home care would be a better option to begin with? Whatever you decide, where all will you get the people? Recruitment. If you want doctors, nurses, excuse me, to support you, we will help you put up that ad on our website, and you can get your chosen doctors and nurses to run a palliative care center. What kind of budget you need to keep in your mind to start a palliative care center? What kind of communication or material? IEC is basically information, education, and communication. This is IEC material is used for generally by the government hospitals where they want to create awareness among the masses for a certain topic. So all those kind of material, if you require, we will support you with that. And of course, the documentation. How to assess? What are the pain assessment documents? What are the different tools to use when you are assessing a particular patient on palliative care? All that these facilitators would be able to work with you and provide you with all the data. One of the things that Syed is showing right now is a very basic standard audit tool. Whenever you come up with a idea of setting up a center, this audit tool will tell you what is essential for a palliative care center. The middle page, if you see, that tells you part A, essentials. You go through it, look at it, whatever is existing, and you can move towards part B, which is desirable. So where you stand right now, do you stand right in the beginning where you have nothing? Or do you stand at a level where you already have a palliative care center and you want to enhance it? Or you are at a level where you're possibly one of the leading organizations and you want to see where next you can enter in. So all those discussions we can have with you and then work with you to expand. This is a standard audit tool. Generally, our quality team does. If you think our quality team needs to visit you, we can visit you and help you out in that. One of the teams that Syed mentioned is about implementation team, where one of our doctors, nurse, and social worker will visit your team on your site, like your hospital, wherever you are working. Our doctor, nurse, and social worker from this setup will come and work with you hand in hand, depending on as long as you want them to be there. Like suppose you have got trained and when you want to go back, you're not able to really feel so confident that am I assessing the patient correctly? Is this the right thing to go about? So we have these experts here who are doing in and out palliative care assessments, dealing with palliative care patients. So they will come with you hold your hand, work with you, see the gaps, see the barriers, try to help you through those barriers. And once you're more confident to set up, once you're more confident to carry yourself at your center, we come back. It can be from 2 weeks to 1 month, depending on your requirement. Thanks, Syed.
Thank you, Shalini. So this is NPPC, National Program for Palliative Care. So how we are working with them? So it's like an interdisciplinary approach. We are connecting with doctors, nurses, psychiatrists, and psychologists, physiotherapists, non-medical, clinical, medical workers, counselors, psychologists, and allied health workers, pharmacists, palliative care assistants, administrators, and volunteers. So our work, just we have to connect.
Sir, we can't hear you.
Are you getting me?
Now we can hear you.
Hello? Yeah, I'm audible now?
Yes, yes, you're audible now.
Yeah, thank you. It's like a national program for palliative care. So integration of palliative care with existing healthcare facilities. So we are connecting with interdisciplinary approach. We are connecting with doctors, nurses, psychiatrists, and psychologists, physiotherapists, non-medical clinicals, medical social workers, counselors, psychologists, and allied health workers, pharmacists, palliative care assistants, administrators, volunteers. So you're saying the palliative care in a center, and we are connecting with all the for up, down, right, and left. So these all we can say unit where we are working in a collaborative way. So we are connecting from doctors to volunteers.
Sir, I'll take a moment on this slide.
Yeah, sure. Please at some point.
Yeah,
yes, thank you.
Some of you might be from a government center here, and in government center, things work differently from a private center. You all must be knowing. Now, government center requires approvals. The government center, for anything that you want to do, you need to go to your medical superintendent or dean if you're part of a medical college, and then further approvals up here. So we just wanted to share that as per Indian Ministry of Health and Family Welfare, they came up with a program called National Program for Palliative Care, which they wanted to introduce through the current healthcare facilities that are available in India. Primarily focus on district hospitals, sub-district hospitals, community health centers, primary health centers, where they think that palliative care services should be implemented. This was introduced in 2012. But till now, the state of affairs and all the government hospitals are not where we wanted them to be. So right now, what we are trying to do is work with these government bodies. So state health is actually a state subject where each state government has to define how they are going to come up with their programs, how they are going to implement their programs, and they have to plan out their budget. There is a whole budget that they always send a request to the central government once in a year, which is called a PIP, plan and proposal, and implementation. It's kind of an implementation plan talking about how much money that you require for the rest of the year. So that particular request, when it goes, you have to make sure if you are planning to open up a palliative care center, or you are planning to do open up a palliative care service in your government hospital, you have requested for money in that particular request that is going to central government. That happens once in a year. You will have to connect with your authorities to understand when it happens. Once that money comes, that has a provision of 1 doctor and 4 nurses to be available for you to have palliative care services. But one of the major challenge that we have seen in government is resource. The resources are so meek that 1 doctor is handling so many programs. Is there any government doctor here any doctor working in a government setup? Would you want to share any of your experience?
Yes, ma'am. Yes, ma'am. I'm Dr. Rosa Ramani, ma'am, from
Yeah.
Tirupati, AP.
Yes, Dr. Rosa. So you know how are you trying to get the money to run your center? Are you planning to open up in your government center only, the palliative care service?
Yes, yes. Yes, ma'am. Actually, Dr. Bharati, who retired in our hospital as a superintendent, no? I
Yes.
worked as a deputy superintendent at the time of Bharati's time. She initiated me to join and learn about, know about palliative care. That's why I joined in this. Now the Rotary Club people are coming forward to start a palliative care unit and support in economically or any building repair if needed. So we consulted our superintendent, madam, Dr. Ravi Paul is there. He is not discouraging or not encouraging to initiate the palliative care, but we are stepping forward to visit what the vacancy rooms are there available to start in government setup palliative care. The Rotary Club people are coming forward to repair the building if needed. So I am interested to start, madam, after completion of this.
That's lovely. Thank you so much, Dr. Rosa, for sharing. And we send in our wishes. I think this is the model where public-private partnership is happening. So I think Dr. Bharti already knew getting money from the kitty of government will be tough. So she
Yeah, yeah.
persuaded Rotary to come
Yeah,
and
ma'am.
invest. And
Chalapati Rao is there. He is a retired chemistry professor.
okay,
He is coming and visiting the places which buildings are in damaging stage. That we are choosing, madam, selecting. That
okay.
having both peripheral PSC worked for 14 years. After that, in service, I did general surgery. Now, professor of general surgery in the SVRR Hospital, SV Medical College. So we are interested to start palliative care.
Lovely. All the
Medical
best,
college.
Dr. Roja. Thank you for sharing your experience.
Thank you,
This is one of the ways, that is what I would like to tell you. This is one of the ways that you can arrange for funds even in your government setup. For a private setup, of course, there are different business models, whether you want to be sustainable, whether you want to charge the patient, or you want to depend on donations and then carry on with your charity work. But this is one of the ways where public-private partnership has worked. Thank you, Dr. Roja, for sharing your experience. Syed, over to you.
Yeah, thank you, Shalini. Thank you, Dr. Roja. So the next slide is, it's like a health and wellness center. So we are working in primary level, secondary level, and tertiary level. So through this is our operational guideline and a strategy regarding palliative care center. So we are working in service provision, capacity building, community engagement, monitoring, and supervision, continuum of care and approach. So what we are working in service provision, first we are working in a primary level, we are connecting with CHS, PHS, and HWS. In secondary level, we are working with sub-district and district hospitals. And territory medical, we are in territory level, we are connecting with medical college and RCCs. And we are also trying to connect outpatient service, inpatient service, and home care service, and outreach activities as well. And we are also working for the availability of drugs and opioids and connecting with the social benefits for patients and family. Through the capacity building, we are just training, providing the training to ASHAs, NMs, and SHO with the collaboration of NHM and government bodies. We are also working, providing the capacity building of nurses, multi-purpose workers, just like MPWs, and with medical officers and officials. So through community engagement, we are sensitization and we are just sensitizing and creating awareness of community. We are also providing the IEC material and intersectorial linkage. And we are also connecting the volunteers and identifying the volunteers, providing them training so they can work in the community. So through the monitoring and supervision, we have some, which we have shown some reports format to you. And so we are working in a reporting for, and we are also providing the audit budget by state program officers and other person who are coming from outside. And the topic of continuum of care, we have a comprehensive primary health care package at CHS, PHC at WS level, and in interdepartmental referencing, patient referral, consultation, treatment, and linkage among C at DHS MC. And regarding the approach, we are providing the quality of life, total SCR relief for all patients, affordable treatment, rehabilitation. Shalini, would you like to add some points on it?
I think, no, thanks for taking that up. I just wanted to let everybody know that these are operational guidelines of the NPPC program. If any of you is interested to understand how a national program for palliative care, how it wants to strategize, how it wants to develop palliative care services in their district hospitals and sub-district hospitals, these are some of the strategies that they are employing, and Pallium India is working with them in different states to employ these strategies and guidelines. We can move on, Syed.
Thank you. So working with the government national health mission, this is our data, which we have done work with the training and facilitation in 21 states and 3 union territories. So there are some marks you can find partners, current or past, that is shows Ladakh, Uttar Pradesh, Rajasthan, and some pointed on red. So we are just approaching, but not approach through Gujarat, Bihar, Odisha, Telangana, and Karnataka. And working in process, we can say Madhya Pradesh and Arunachal Pradesh. So you can see that we have covered across the India, but few states and units remaining. We are also working on it and hope we will cover it as early as possible.
Syed, just if you can,
yeah,
sorry
yeah,
to interrupt.
Please.
You can just
Yes.
go back.
Yeah. No, it's important.
Yeah.
Yes.
Here, I just wanted to bring up to everybody's notice, there is this National Health Mission. This is the organizing body which is working in every state on palliative care services in government centers. The whole idea about showing this map is that all the green states, Pallium India is already present in some form or the other. We have been working with National Health Mission, either for training or for facilitation, wherever we are working with the doctors or the nurses of their hospitals to have palliative care services there. National Health Mission is the body which supports with money. The PIP that I told you about, the money comes to National Health Mission and then it gets dispersed to the district hospitals, sub-district hospitals, and further down for work. There are medical colleges also, which are tertiary care hospitals. For them, the state has a separate budget and we have to go through a different process for that, and each state follows a different process for it. So if there is anything that you require to help you in your state, we'll be happy to. I just wanted to highlight one thing, that reds and yellows here doesn't mean that National Health Mission is not doing any efforts from their own side. This just means that our presence is not there. There might be somebody else working there. Like in Gujarat, we have Dr. Geeta Joshi. Anybody from Gujarat here in the group?
Yes, madam. I'm from Gujarat.
Yeah. Hello, Dr. Hetal Kumar. Which city in Gujarat are you from?
I am from Rajkot, ma'am.
Rajkot. Nice to hear, sir. So in Gujarat, we have in Ahmedabad, we have Dr. Geeta Joshi, who has a community oncology center, which is a hospice, and GCRI is one of the big hospital catering to palliative care. They are primarily catering to cancer patients, but they also deliver palliative care through a lot of services. So there we have kept it red because they are the ones working, they are local experts, and they are the ones working with the National Health Mission or the government bodies to expand the palliative care services. Similarly, in Karnataka, we have Karuna Share, who is primarily working with the National Health Mission. Telangana, we have Dr. Gayatri Palath, MNJ Cancer Institute. Bihar, we have AIMS Patna, where they are working with AIMS, Dr. Sushma Bhatnagar and all, to establish palliative care services. Odisha government, again, Karuna Shah is there with their Odisha branch, and they are already coming up with a hospice called Bakshi Karuna Shah Hospice, and they are working with the government there. Yellows are basically the ones where we are already some work is happening, but we are not able to make a partnership so far. Any questions on the government setup? Yeah.
Ma'am, actually, I am in Rajkot and we have a trust hospital where we are planning to start palliative care.
Great.
But regarding training program, I think we don't have much resources. So as you told us, people from Pallium India can come here and train us. So how much will be the cost to the hospital for that? So what are the charges I wanted to ask?
So, Dr. Edil Kumar, thank you for asking that question. We have different costs involved, and that is generally by the actuals. Actuals in the sense, whatever cost is involved for taking the team from here to your site and helping you build it. But before our team comes to your site, we would want to ensure that the doctor, nurse, and the team is already trained in theory classes, like the way you are trained right now online for theory classes. At least that kind of a theory training has already been done. Then only our team from here would come there and handhold further. That is one option. That would only involve the actuals as in whatever is the cost of the 3 people, 4 people coming from Trivandrum to Rajkot and staying for as long as you want, and the food and the local travel. So,
right, right.
And it is very, very, why I'm not giving you a particular number right now, because it all depends on the capacity of the organization. Like I'll give you an example. If the organization has their own internal guest house, the cost of the accommodation is gone. So we might give you a cost, meaning like your basic room is costing 2,500 per day, multiply by 4 people. We don't want to get into that because it depends on your capacity, what you have.
Yeah.
So we will have a separate discussion, and then we can come on to a budget for each site.
Right, ma'am. I got your point. Thank you, ma'am.
No problem. One more option we have is where we send our trainers on site. We send our trainers on site is like the 10-day, the foundation training that is happening right now online. That same foundation training can happen for 10 days, wherein our team can come at your site and conduct a training for 10 days continuously. You can create a batch of 30 or 50 people. 30 would be the most appropriate. New people who do not have any palliative care training, our training team will set up resource people. They'll send our very proficient faculty. They will go there, do a theory class for 5-6 days, then give you a hands-on training within your setup, do an assessment, give you the certificate, and then come back. So that is completely different. That's like doing on-site training for you, for your organization.
Right,
and post that comes the implementation team that I talked about, that they come and handhold you and stay with you as long as you want.
Got the point. Thank you very much, ma'am.
You're welcome, sir. Any other questions? Okay, over to you, Syed. Thank you.
Thank you so much, Shalini, for adding some very important point for this slide. Thank you so much. I'm just going to next slide. So this slide is regarding to working with government regarding opioids availability workshop. So we have covered near about 24 states and union territories, and we are working in a progress to organize this opioids availability workshop in 6 states, and we have not approached. So we are just trying, but not approached 5 states and union territories. So you can find we have conducted the opioids availability workshop, which is marked in green, and working in progress. You can see some yellow, Madhya Pradesh and Assam, and red. In the red color, we can say Telangana and Karnataka and Tripura. The map is showing that how we have worked for the opioid availability workshop. Sunny, would you like to add any points on it?
Yeah, just wanted to tell you, this is some of the things that, again, as whenever you open up a palliative care center, after capacity building, you need to have medicines. That's a very primary thing to start a palliative care center. Now, in palliative care, medicines means opioids also, not just the general medicines, but opioids as well. Procuring opioids has a different setup, that has a different process altogether because of the fear of its misuse and people, the opioids getting pilfered. So for that reason, there are strict rules around it. There is strict documentation around it. And for that, we create awareness. So these opioid availability workshops are those awareness programs that we have done with the drug controllers of the state. So all these green states that you have seen, our team has been working with those drug controllers to create awareness about how to procure opioids for their institute. Like how to take up the new certificate, which is called the Recognized Medical Institution Certificate for your own center, and then get opioids, that is your morphine, fentanyl, and methadone. So in Madhya Pradesh, Assam, and Karnataka, Telangana, again, yellows and red doesn't mean that it doesn't exist. It's just that Pallium India is not able to penetrate that area till now. So if any of you can connect us with the drug controller of those states, we would love to create an awareness program for the entire state. Particularly for Andaman Nicobar, anybody from Andaman Nicobar, please connect us with the drug controller there. We have been trying to find out, but we have not been able to make a connect. Thank you, Syed.
Thank you, Shalini. So we are moving to next slide. So this map shows regarding working with government policies. So we have covered in 9 states, red, yellow, and green. So green shows that state policy created. Yellow that the state policy has drafted and submitted. And the half yellow with red that state policy drafted but not submitted. And the red that's showing just we have to connect with them. So Shalini, please add some point on it.
This particular map might not be, of much relevance to you right now, but this will give you an overall picture of your state, how the palliative care services are there in your state, wherever you are. Overall, only 4% people in India are receiving palliative care or pain relief. Now, this clearly shows why. Only the green states already has a policy on palliative care. Kerala had a policy since 2008, and then they revised it in 2019. And that's the reason why Kerala is still leading in the palliative care services. But we need to bring all the states to that level. So we would request each one of you, when you go back, try to open up palliative care centers, new palliative care centers, so that people can have more access to the services. This is more at a policy level that Pallium India is working with the primary local organizations who are interested to work with the government and then come up with a state policy. So probably not right now, later on when you're already established with your centers and you want to contribute more towards your state, that is when we can work with you on this. Go ahead, Syed.
Thank you, Shalini. So these government bodies, NHM, DHS, FDA, Food and Drug Administration, and the state level. So these numbers of activities we are doing across the India. So I just wanted to mention the name of activities and numbers and name. So number of activities, the state on-site training. We are providing the state on-site training. We have covered the 6 numbers, and in Meghalaya, Mizoram, Tripura, Haryana, Andhra Pradesh, and Goa. And so the next activity is this TRIPS training. So we have covered 4 numbers: Himachal, UP, Kerala, and Tamil Nadu. And online FCPM, FCPN, VTP, and Pali-COVID training have been covered. Number 16 in Meghalaya, Sikkim, Mizoram, Nagaland, Manipur, Ladakh, J&K, Haryana, Punjab, Rajasthan, UP, UK, Chhattisgarh, Madhya Pradesh, Tamil Nadu, and Andhra. And implementation from the regional facilitator numbers into Haryana and Uttarakhand. And Hamrahi, we are also working with the Hamrahi project. The number is 3. We have covered Tripura, Mizoram, and Lakshadweep. And we have also created the awareness. Number is 4. Nagaland, West Bengal, Jharkhand, and Maharashtra. And we have conducted the opioid ability workshop. The numbers is in 24 states. That is called Meghalaya, Sikkim, Mizoram, Nagaland, Arunachal Pradesh, West Bengal, Ladakh, J&K, Haryana, Chandigarh, Punjab, Rajasthan, UP, Uttarakhand, Jharkhand, Bihar, MP, Gujarat, Odisha, and Madhya Pradesh. And we have also covered the state policy in 9 states: Tripura, Himachal Pradesh, Uttarakhand, Bihar, Odisha, Tamil Nadu, Andhra, Kerala, and Karnataka. And NHSRC, CHO, we have covered 3 states: Assam, Ladakh, Uttarakhand. And we have also done the MOUs with 1 state in Maharashtra. And hello.
Yeah, somebody wants to ask
Yes,
a
yes,
question.
yes, please.
Ma'am, this is Dr. Iskeda speaking from ICMR, Assam.
Yes, yes, Dr. Das, please go ahead.
You have said that in Nagaland and in Manipur, along with Tripura, you have already worked with organization. May I know which organization you are working there?
So in Nagaland, we have partnerships with the CIHSR, Naga, that is Christian Hospital. Dr. Tony Biswas is there. We
Okay.
also worked with Dr. Tete when she was there in this Naga Hospital Authority, that is Kohima. Earlier, Dr.
Okay.
Tete was there. Now, Dr. Takito, I'm sorry, it's a difficult name. I'm not able to remember right
Okay,
now.
no issue.
Yeah. Then in Tripura, we worked in past, we worked in 2017 or so. We worked with the National Health Mission there. We conducted training program on site. Now we have Dr. Arup Roy Burman, who is the NPPC nodal officer. So he is running it. So we are not able to revive our connections. So if you know, we would be happy to work with them again. And I forgot the third state you asked.
Manipur.
Manipur, we have worked with the drug controller. I personally visited Manipur, met the drug controller in his office. We explained to him about the RMI rules, because Manipur has not come up with the recognized medical certification till now. It is something that is new, and because of the unrest in Manipur, we are not also pushing too much to them, because we understand they might not be in a right state of mind. But we have partners in Shija Hospital. You have Dr. Surender. We have Dr. Nandan Chaudhary in one of the private hospitals. Forgetting the name. So with them we are working.
Because why I'm asking is because one of my friends that we have earlier worked with non-communicable diseases, Dr. Samarjit, he is now the mission director in NHM and based at Manipur, Imphal.
Okay. He's the NHM mission director?
Yes, based at
in Manipur.
Imphal itself, Manipur. So
great.
we had earlier worked with him in one of the IDSP project and non-communicable disease projects itself earlier.
That's great.
Recently I came to know that he is now the mission director based at Imphal itself. And also in Tripura, as you have said, some Burman.
Roy Burman, yes.
Right. He's based at this Agartala Government Medical. Okay.
He's based in Agartala. He's working in, I think, with DHS only, Directorate of Health Services, or NHM. I don't know recently where he has moved, but he's there only.
In fact, because we frequently see that the NHM director moves from one department to another. So in that case, what happens to the program itself then? Suppose he is not in the interest.
Yeah, very good question, Dr. Das. That's one of the major challenges that our team faces, We go,
Yes.
we meet up from top to down, everyone,
Yeah.
we train them, we do everything, and suddenly all the transfers happen and they are moved out. And we are
Yes.
still back to the same position.
Yeah.
That's exactly
Yes.
one of the challenges we are facing with the government institutes. But what we have done is certain governments are very, very focused now, and they are training their people, and whosoever is trained, they are tracking them, which hospital they are right now, wherever they are, they should start their palliative care services. Some of the strong states, I'll tell you, in Haryana and Uttarakhand, they are very focused. Our people are working with them, and with every district hospital, the team is working, the regional facilitators are working, and whatever problems they are facing, they are trying to clear them up so that before they get transferred, there is a palliative care service there running.
Yeah. In fact, do not you have any MOU working with the state government if they are working, if they wants to work with you? Any state government people?
Sir,
Tripura, Manipur?
yeah, two things we would love to have an MOU, because that just gives us a strong sense
Yes.
that yes, we are working with the state. But so far we
Yes.
only have MOU with Maharashtra, but our MOUs with Himachal, Uttarakhand, Haryana, UP are in the process. We would be
Okay.
having them. But to tell you, Dr. Das, there are a lot of times MOUs are signed and the work is not done. There is nothing happening on the ground. So we do not
Yeah.
focus on the MOU, we rather focus on the work that is happening. So our regional facilitators work with individual doctors, whosoever they find interested in the NHM, they go and start working with them. If we get an office order, we will work with an office order. If we do not get an office order, we work without any agreements. The whole idea is whenever we see an interested person, we just go and join them and support them. But we don't wait for an MOU or an office order to start working.
Because state governments, they are Mexican, they are basically, they want to go for MOUs itself. And if MOUs are made, then he or she, any doctor coming to this palliative care program will give much more boost to it. Because he or she will be the person nodal person who will be contacting after it. Anyway, once I come down to Pallium India next month, no, in April, we'll talk at the integrities. That will be much better.
Sure, sir. Most welcome. I'm looking forward to talking to you.
Thank you.
And do connect us with any other states, NHMs or bureaucrats you know.
Right. Yes, yes.
Even in defense, the problem is transfers. Once someone is interested, GOC is interested, they build something, but once they are gone, it ends with them. That's the hardships in defense as well.
Let us see, we find a win-win solution for all. It will be much better.
That's right, sir. I think we all have to act fast. We get trained and quickly we should open up service and quickly we should create a backup so that before we are moved to another place, there is proper setup there. So I know Dr. Divya was trying her best to start a palliative care center in Bangalore Command Hospital, and then she got transferred to Chennai. Now she's trying her efforts there. But I tell you one thing, whatever efforts you make at one center, sooner or later they would give fruits. It might not give fruits immediately, but little later it will give fruits. I'm sure somebody will pick, but it's great to see whatever efforts you have put in before you are transferred, that becomes a solid plan.
Right.
We'll have to work faster.
Yeah, in fact, working because every cancer hospital now has a palliative care unit. So let us try to at least, I mean to say, regenerate them itself.
Correct, sir. Correct.
Right.
Thank you. Thank you for sharing your thoughts. There are a lot of questions in the chat box. If you don't mind, we will take it in the end. I might be missing some or the comments as there is such good interactive communication is happening right away. So we'll definitely take those questions and comments in the end. Before we move on, just wanted to tell you, this is a quick picture of the work that Pallium India has done. So you are from all over states, so you can see that your state is trying to do some work. They might not be very successful, but probably you can be the mover, the enabler to push them to do more if you're working in a government setup. So just that is the takeaway of this slide, I would say. Syed, over to you.
Yeah, thank you so much, Shalini, and really it's very important points you took. And we have a MOU with the Maharashtra government, and there has two states that have come to tips. We can say Tamil Nadu and Andhra. And Shalini, also you told to all the participant about the implementation team, which we are trying to connect with the governments and their bodies to connect with the implementation team to add values in their palliative care centers. Do you want to add something on it?
Yeah, as I mentioned, implementation team is where our team goes and be with you at your site. But with government particularly, we are trying to find our implementation teams should go to their district hospitals, work with those teams, and then so that it might go faster. As we were already discussing, before they get transferred, we want the setup to come up. So that's why the moment we train those people, we are pushing them to have our implementation team so that on the ground, they will be able to handhold their teams and go ahead. So far, we have got a request from Uttarakhand. We are still working with other states. Hopefully, we'll be able to make a mark soon on this. Thanks, Sayed.
Thank you, Shalini. We are moving to the next slide. This is the World Health Assembly 2014. That is shows that how you will create the palliative care units for palliative care integrated into all healthcare centers. And community partnership in care is very important. So if you wanted to go through the palliative care unit, you have to go through the community partnership in care and palliative care integrated into all healthcare. Then we can achieve our goal to catalyzing the palliative care center across the India. Shalini, do you like to add any points on it?
Yeah, this is one point. Once you have set
Hello?
up your palliative care unit, once you have established your OP, IP, or healthcare unit, this is the next level. This is the next level of engaging the community. Like you have already started your services, now you want the community to send volunteers and work with you. One of the major things that we lack in social capital, we have to get salaries to get a team or select the right kind of people to run the show. But if community joins you, they take the ownership of the people who are sick in the society, and then they connect the provider and the receiver. And in between, the community acts. That's exactly the model followed in TIPS, Pallium India. And I think once you reach to that level, once you are established, we would work with you to start up community partnership in the care of the patients.
Thank you, Shalini. We can move to the next slide, right?
Yeah. I think this is
this map shows that what you talked and okay, this is a live slide. Shalini, please add some points on it.
No, we will just, what we'll do is, Syed, we will give them the numbers of all our regional facilitators. So each of them in the chat box,
Right.
we'll just put all of your numbers so that they can reach out to you
Yes.
depending on their states.
Definitely, yes. So now the participant can then you can read the message and start the question answer session now.
Okay. Thanks, Syed. Can you
I'm just closing this
system,
right?
The numbers of everybody in the chat box. Yeah.
I can say Jatin's number is not there.
Yeah. Jatin's number will add. Great. So going back to the chat box, we'll begin from.
Ma'am, can you send these numbers on WhatsApp group?
Shipra, is there a WhatsApp group?
Yeah.
Okay, great. That is also sent, and Jatin's number is there? Yeah. There are 6 regional facilitators around, and it is also the same information is available on our website as well. So
Okay.
you can reach out, or you can send my number also. If by chance you're not able to understand whom to contact, you feel free to contact me also.
In fact,
Yeah, go ahead, sir.
this is again Dr. Das speaking.
Sure, sure.
In fact, our endeavor should be that whatever work has been already done, we did not replicate it. Rather than we should try out what new things can be added to the existing program itself that you have already started.
Correct, sir. I completely agree. That's one of the things we are trying with the government centers, because government centers, I don't say everybody is like that, but they probably do not have the expertise to run the palliative care services. So their
Right.
main focus is just to train them. So every
Yeah.
time only the training keeps happening. You know,
Mhm.
the team keeps getting trained and then keeps getting transferred, and they are not able to start. However, now what we have started pushing is, where are the people who have already got trained last year
Yes.
or the
Yes.
previous year? Find them
Right.
out and see whether they are doing palliative care services in their centers or not. And
Mhm.
there we'll pick and work with them to start the services.
Yes.
So
Yes.
that's exactly rightly said. That's what we are focusing on right now.
Thank you. We have more discussions when we comes down to Pallium India.
Sure. And if any of you want to have any particular discussion separately with us, how to start running your new center, or how to enhance your current center, or how to get into community, or for that matter, anything, particularly you want, you're already palliative care trained, but you want more expertise on pediatric, or you want more expertise on HIV, you want more expertise on neurological disorders, let the regional facilitators know. We will set up, customize it for you, and probably have some workshops, some training. We'll work with our training team and we'll design something for you. Whatever possible, we'll work with you. So you can reach out to us for any requests.
Can I ask you on, if time permits,
Sure.
can I ask you something?
Sure.
So good evening, ma'am. I work as a private practitioner.
Yeah.
I have my own clinic, but I would like to, recently, I mean, in my area, I do a lot of home visits for the terminally ill patients. And like everyone knows that I do home visits. Maybe probably I'm the only one doctor who does home visits for the terminally ill patients. And I also take telehelp from Pallium India. You know, sometimes when I'm stuck and I feel I'm not able to, Dr. Sridevi has helped me a lot of times to how to go about. What I want to ask is, if I want to set up a 4 or a 5 bedded daycare unit, a palliative daycare unit, which I'm planning in future to buy. I mean, how do I go about? I mean, where do I mean, how should I, what type of bed should I buy? How is it going to be licensed? I want to, that's my dream. I mean, my final dream, to start a daycare unit, just a daycare unit. I mean.
Okay. Ma'am, you will have to, even if you're opening up a palliative care center, it comes up under the law of nursing home or the clinical establishment only. So you will
Okay.
have to have all the certificates of that clinical establishment, which is generally applicable to a hospital or a clinic or any medical institute, any private
Okay.
medical. And that is very state specific. So you will
Okay.
have to possibly connect with one of your colleagues who's already having a center in a hospital in your city. Which city and state do you belong to?
So I belong to Mumbai suburbs. I mean.
Okay, Mumbai suburbs. So in Maharashtra, how to open up a palliative care center or running a establishment in Maharashtra, I think the best person is to ask your colleagues which all certificates that they went through and which
Okay.
all licenses that they went through. Because to be honest, we are not experts in every state's establishment rules, clinical establishment rules. You can out here, I know Dr. Prasanna Menon is there, who's already running a palliative care center in Navi Mumbai.
Okay.
And I'm sure she would know all the certificates and the
Okay,
formalities.
I'll get in touch with her. I'll get in touch with her.
But to more, Thane. Sorry. I don't know why I always think you are in Navi Mumbai, Dr. Prasanna. So sorry. Please guide Dr. Rathore on the certificates or the legal process that have to go through. But I would suggest, to be honest, if you want to have any palliative care OPD, that doesn't require a big planning. You can start with a small room also. I know of a doctor in Gujarat who was working in government center, but he wanted to do some some palliative care. So like Dr. Rathore, you are doing, he just started on his bike, took his bag, put some medicine into it and started visiting people in their homes. And his palliative
Okay.
care services started. So, but
Right.
yes, if you want to establish a small center, then to begin with, one room is enough where a patient can come and sit, and probably a stretcher. That should not be too big. But depending on your capacity, like you said, you want to start 5 or 6 bedded
3 to 4 bed
inpatient.
also, because I don't want
3 to
night. I want only in the day. It should be like a daycare.
Yeah. So you will first have to decide on the infrastructure, where is the land, where is where you want to establish. It should be accessible to patients, that people can reach there. Then there should be enough space for both family and the patient to stay there when they come. You need to have staff, capacity building, and of course the infrastructure. We are also learning right now. Pallium is establishing its own Pallium home. We have been, for the last 30 years, we have been shifting from hospital buildings to hospital buildings, and whatever we find, we adjust to that and then carry on. So if you want to really start off with the proper setup, then probably involve an architect to just help you set up those things in detail. We can always come on a separate call and share a checklist with you, that what all things that you need to have in your center. We already have a checklist with us. We can share that with you.
I think I can, what I can do is I can go and visit Dr. Prasanna Menon's center first.
Correct. That is like seeing is believing.
Yeah.
So yeah, you go ahead and, she'll be the best person to tell you how to start establishing a center to begin with.
I'll do that. Okay. Thank you, ma'am.
Welcome. Is it free services or pay visits? Dr. Roja, is this a question to Dr. Rathore or is this question to me?
It's paid, ma'am, mine.
Okay, yeah.
No, madam. Sir, for sir, madam, not for you.
Okay.
Sir is doing paid services or free services. That's what I want.
Yeah, as she mentioned, it's paid services, I think. She's yeah, it's paid services. Ma'am,
It's paid, ma'am, but it's like I don't mind doing free. I mean, the affordables, those who can afford, they pay. There's something I have done free also. I mean, for few patients who they stay in a chawl and like very non-affordable patients. For them also, I have gone for home visits. There, I don't charge them then.
Correct, Dr. Otto. Thank you for doing that, because I think what happened is palliative care services started with more of a charitable model. It is always free. But because of that, what happened? The poor were getting the palliative care, but the rich were not getting, because it was free. So it was below their dignity to actually avail these services. So now one of our focuses to have palliative care.
Yeah, 100% correct, madam. Some people are thinking that when you are giving charity, they underestimate us. What they are giving, they are freely what they don't take much care, like that they underestimate.
They'll question your quality, or they'll feel, no, this is not up to their standard and they cannot come. So that's why one of our endeavors is to open up palliative care centers in corporate hospitals. We are approaching corporate hospitals to start home care services and get benefit also, because then only they are self-sustainable. Some of them just want to work on a subsidized rate, not charge much, but also to add value, to make sure that patient is taking it on some value to that service. So they're charging very minimal. So there are different kind of models, as Syed shared. There are different government models, sustainable, private, standalone, all different kind of models are there. So we'll work with you for any model that you want to.
I wish to start as a minimal pay services, a home care.
Sure, ma'am. Sure. We will love to work with you, have a detailed discussion, and wherever we can share things, we would share with you.
Thank you, ma'am.
Any other questions? Otherwise, we go back to the chat box. Anything left out in the chat box? Dr. Farhana, if I can bother you, if there is any question we left out, I know you had been answering few.
Yeah, there was a question regarding palliative care assistance. So I just replied to that.
Okay.
Apart from that, I think there were discussions between two people regarding how is it going and all of it, whether it is free or paid service and all of that was discussed. I
Okay.
don't think then your number was asked. It was shared by Shri Priya there.
Okay, okay, great. I don't see, Dr. Prasanna Menon, you have written, you will require some assistance regarding scaling up services. I think I replied because I know a little bit about your center and I know you're already doing it. You are at a level of where you can probably enhance the quality more. So that's why I'm suggesting an implementation team where our team can come there and work with you and just see where are the gaps and then suggest you better things. Okay. I think we have touched upon all the comments and questions. Unless there are any questions here, feel free to ask. Happy to answer. Okay, seems like all questions are answered. No more questions. So please feel free to reach out to any of our regional facilitators. Dr. Jatin Bukkal is one based out of Chandigarh. So he will handle queries of Himachal, Chandigarh, Punjab, and Haryana. Others, Shripriya has already sent it. So I think we'll call off, wind off the day. Thank you so much for being such an interactive audience. And Syed, thank you for making us go through that entire presentation of yours. Thank you for making them get introduced to this organizing palliative care.
Thank you so much, ma'am, as well as Mr. Syed, because I think you have touched every nook and corner, and it was a very elaborate session. You have answered all the chats and comments and everything, questions and all. It was really a very nice session. Thank you.
Thank you. Thank you, everyone. It's been, I think it depends on the audience also. When the audience are so interactive, coming up with so many questions, you also get excited and you want to touch upon everything. So there's been a wonderful audience today. So thank you for such an interactive session. Syed, you want to say something?
Yeah, thank you so much, Shalini and Shripriya and all the audience, really. So it was very, because it was a two-way communication, right? So it's very important in any subject to when it's happened, a two-way communication. And really, I think it's this session we have taken up both the two-way communication. A wonderful audience. Thank you, everyone.
Thank you, Mr. Syed, and thank you everyone for joining in. We believe that as an organization also, we can't do anything if we don't get support of people from you, from across the places. So that is what we always look for. So with the promise that we'll be meeting in the next session with another important topic and yet another eminent faculty. This is Ripriya, along with Mr. Syed and Ms. Shalini signing off from the Tips Eco Hub. Till the time we meet again, stay connected, be happy. Bye-bye.